Welcome to another edition of Talking Away the Taboo. I am thrilled to be bringing you this conversation with JScreen. Again, we're on part four, I think, of a year-long series that we have been doing with them on all kinds of genetic diagnoses or overall genetic topics and how it relates to your fertility. And so today we're actually going to be talking about the BRCA mutation and associated cancer risks. And first of all, I have a number of experts here, and I also have a woman who is going to be sharing her personal story. So I just want everybody to introduce themselves so that the audience can get a sense of what your voice or your depending on whether you're watching this on video or whether you're listening to this on the podcast. Let's let everybody go around and just share just a couple of seconds about yourself as a quick introduction. So, Emily, I'm going to turn to you because you are our JScreen representative. So please go ahead.
Sounds good. And thank you for having us again. My name's Emily Goldberg, and I'm a licensed certified genetic counselor with JScreen and the director of genetic counseling services at JScreen. And we're a national nonprofit, and our goal is really to provide access and awareness about genetic testing, both for hereditary cancer and reproductive genetics.
Amazing. I'm totally going to be embarrassing myself right here. And I want to introduce our physician on the panel, but I am not 100% sure how to pronounce her last name. Is it Dr. Frey or Dr.
No,
Frey?
no worries. My name is Melissa Frey. Just call me Melissa and make it easier. I'm a gynecologic oncologist, and I also am the director of the Genetics and Personalized Cancer Prevention Program at Weill Cornell Medicine, which is a program really aimed at offering genetic testing to anyone interested and helping individuals living at higher risk for cancer take advantage of preventative and risk-reducing medical options.
Amazing, amazing. And first of all, I will be using your MD, your doctor title, because I myself am a pediatrician, and as everybody likes to say, I spent a lot of years earning that degree, so we will be using it. So, Dr. Frey, thank you so much for being here. And now I'm going to introduce our guest panelist, someone with her personal story who's going to tie this all together for us. Heather, share a little bit about you, a little bit about your background, and give us the window into your fertility story as to why we're having this conversation today, and how it has affected your life.
Sure. Thank you so much for having me. This is my first podcast, so I'm very excited for this whole journey of our
We're
conversation.
We're excited to have you. Thank you for letting us inaugurate you into being a guest on the podcast. You'll see now, like everyone's gonna be clamoring to have you as a guest. So you'll see. Don't worry, it's coming.
Well, thank you again. So I'm Heather Boussi. I am a mom of three kids. I live in Englewood, New Jersey. I'm actually a patient of Dr. Frey, who is a rock star. Just so happened that way, so it's meant to be. And yeah, my BRCA story, I'm happy to share with, the listeners and anyone that could be helpful. So my BRCA story started back in 2010. I was a senior in college slash newly graduated, and my mom unfortunately got diagnosed with colon cancer. Thank God she's fine and, she's in remission. They requested that she get tested for genetic testing for cancers and especially BRCA because we're Ashkenazi Jewish. So at that point, she was deemed BRCA2 positive. I was 22. I was, relatively young. And the medical advice then, and I believe it's still now, is that there's really nothing to do in terms of actionable items until the mid 20s, unless, or if you're family planning. So I decided to wait a little more time. I was dating my now husband. We were not married yet. I was younger. And fast forward to 2016, I was newly married and ready to open the door to family planning. In addition to that, and I just felt, now it's time to know my risk and to see if I needed to take any actions. So at that point, I pursued genetic testing. This was just to back it up a minute, like 2010 was BRCA was not so well known in terms of like the general population. This is before the Angelina Jolie article. I don't know if anyone knows about that, but that kind of blew the lid open in terms of people discussing BRCA and how it impacted families. And so it was in my like mind, but it wasn't like forefront. And then fast forward to 2016, it was much more discussed, and I was of age to like really get this going if I needed to get it going. Um, so anyway, that year in 2016, I decided to get tested, and we knew my mom was BRCA2 positive, but I just had this feeling the night before my results that, I just felt like it's so weird. Like my dad's mom passed away from breast cancer at 41. It was really young. Um, and I just felt like, I don't know what that's about, but we'll see the next day. So I went in for my results, and the geneticist said, like, we're sorry to share that you did inherit BRCA2 from your mom, but you also have BRCA1. Um,
Oh, wow.
yeah, it was a very, I still get emotional talking about it because it's like one of those moments in your life where you're like, whoa, like what does this mean? Like, how is this going to impact my life? And at the time, it felt like getting hit by a freight train, honestly. I was just like, "What is happening? Like, this is crazy." But, I was so blessed that Dr. Offit was actually in the office, and he was one of the people that discovered BRCA2, and he came and, like, held my hand. Something about being in New York is, like, we're around all these, like, incredible medical facilities and, like, medical giants, and I'm just, like, so, like, it was just such a blessing that he was there, and he sat down with me, and he's like, "Heather, this is not just, like, take a breath. This is not a death sentence. You're gonna, like, figure this out and take all the appropriate actions, and, like, this is really good, solid information. Like, this is good that we know this, and you're gonna tackle it."
I'm going to pause you here, actually, if it's okay. And
Sure.
I want to turn to Emily and Dr. Frey to talk about, like, what does it mean when someone says, like, they have this in their family? Like, can you give an overview on what the different mutations? Because, Heather just mentioned BRCA2, BRCA1. Emily, let me just turn to you first. Can you just give us an overview for someone who has no idea? I mean, and assumingly that's what Heather was at that moment. What's like what do people need to know when they start hearing this term that something like this is in their family?
Absolutely. So, BR and BRCA2 are genes that everybody has. And we have two copies of these genes because we get one from the egg, one from the sperm. And when these genes are working normally, they're there to protect us from cancer. They're keeping an eye on our cells, they're trying to keep everything in check. So, it's sort of this natural protection that we're all born with. And if somebody has a pathogenic variant or mutation or a change in this gene, it means that there's sort of a typo in that sequence and it makes the gene not work in the way that it's supposed to. So we can lose some of that protection and be more susceptible to certain types of cancer depending on what gene is involved. And there's a number of genes like BRCA1 and 2 that contribute to cancer risk, but these are the ones that are um, often the most common and the most known about, and obviously the topic of today. And so when someone has a variant in one of these genes, it doesn't mean that they're definitely going to get cancer, but it means that their risk is higher as compared to the general population. So, for example, their lifetime risk for breast cancer for women can be as high as 80%. BRCA2 is also associated with an elevated risk of male breast cancer. These genes have an increased risk of ovarian cancer as well. Depending on the gene, can be somewhere between about 20 to 60% lifetime risk. There are also elevated risks for prostate cancer, pancreatic cancer, and melanoma. So the idea behind doing genetic testing and identifying who has these higher risks is we can refer them to someone like Dr. Frey, who can help with screening and prevention and risk reducing surgeries so that by knowing our risk, we can actually take steps to reduce those or detect things at early, more treatable stages, or they can be used to help treat cancer for people who already have a diagnosis, that information can be helpful in those steps as well. These are inherited, which means they can come from either one parent or the other, or in some cases, like with Heather, from both. And those can be passed on from men or women to men or women. The risks can be a little bit different depending on which organs somebody has. But we can always, review that information and talk about what those risks are and, what steps they can take.
So can I ask you, and I don't know whether this is a question for you or a question for Heather, but maybe it's both of you. So Heather said that it was when her mom got colon cancer, that was when she discovered that there was the BRCA2 gene in the family. But you didn't mention colon cancer as one of the things that it has an increased risk when you have BRCA2. So was that just like an incidental finding, or is it that there really is an increased risk of colon cancer as well with BRCA2?
Based on the data we have right now, it was probably an incidental finding.
Okay.
We don't have data right now that suggests that the risk of colon cancer is high enough to use it as to increase somebody's colon cancer screening or think that their risk is elevated over a general population.
So basically, this was a lucky finding, so to speak, in that I mean, it sounds like, thank goodness that your mom is doing well and she's in remission, but that diagnosis spurred them to do genetic testing, which what all cancers at this point, people are trying to determine if there's any genetic link. And then they found this incidentally, and then that gave more information to you, the next generation, in terms of what does that mean for your family? Did I get that right,
That's okay.
Emily?
Yes. And interestingly, if I were to draw out a family tree of Heather's, I would look at her dad's side and say, that's actually more suspicious for BRCA because of her grandmother who had breast cancer at a young age. And I think a lot of times, dad's side of the family is left out and saying, well, my mom didn't have these cancers, so I'm off the hook. But really to put together both of those pieces.
Mhm.
And I think, it's also more evidence to say that sometimes general population screening and making genetic testing available to everyone helps us find things that we otherwise would have missed. And then Dr. Frey, sorry, I think I cut
No,
you
I
off
was
there.
just going to echo what Emily said. As someone who is, spending their life working on genetic testing, I can't not state that, we know that 1 in 40 Ashkenazi Jewish people will have a BRCA1 or 2 mutation. And if you actually kind of looked at everyone's family history, we would probably miss about 50% of people who have this mutation if we only tested based on the guidelines for testing. And so I definitely think there is a role for at least offering everyone, especially Ashkenazi Jewish people, kind of routine population-based testing, because we don't want to wait for a cancer to prompt this testing. We want to find the mutation prior to the cancer.
Yeah, I mean, now I was wanting to turn to you anyway, because the reality is that when you get a positive on these specific mutations, there's a lot that can be done that for in a million ways. So can you tell us more about that?
Absolutely. And sort of the first thing I tell someone when I meet them who has a mutation like BRCA1 or 2 is that this is not fatalism. This is knowledge that's going to give us power to prevent you from having any of these bad outcomes. And I think that's very important. And I think that's the barrier that prevents most people who are at risk from testing, because they're so worried that this is just scary information and there's nothing actionable. And hopefully I can convey today that there are so many actionable things that we can do so that we can prevent cancer altogether or catch it at its earliest stage when it's most curable. So starting with breast cancer, if we know someone has one of these mutations, we start screening earlier. We start MRIs at 25. Then when someone turns 30, we add mammograms. So each year a woman is getting both an MRI and a mammogram. And then for women who say, I don't want to just catch a cancer early, I want to prevent a cancer, we talk about the option for risk-reducing surgery or risk-reducing mastectomy. For ovarian cancer, it's a little bit different. And as Emily said, the risk of ovarian cancer can be as high as 60% in some women with BRCA1 mutations. The problem with ovarian cancer is there is no screening that seems to work. And when we catch ovarian cancer, it is almost always at an advanced stage when treatment is difficult and cure is extremely difficult. And so, really, we want to prevent ovarian cancer because we don't have an MRI or a mammogram that works for ovarian cancer like it does for breast cancer. And so, the prevention is surgery, and it's removing the ovaries and the fallopian tubes. For women with BRCA1, we recommend that between age 35 and 40. And for BRCA2, we recommend that between age 40 and 45. There's a lot of excitement right now about the theory that ovarian cancer actually begins in the fallopian tube and not the ovary. And that's exciting because the fallopian tubes don't make hormones. And so theoretically, if we prove that all of these cancers begin in the tubes, we could just remove the fallopian tubes and then go back at a later date for the ovary and not cause premature menopause and leave in ovaries, which also leave open some reproductive options. But I would say those are the two main strategies we're doing for ovarian cancer prevention and breast cancer early detection and prevention.
I love that. I mean, I also love the way you described it in terms of like, this is not fatalism. This is not a death sentence. This is power. This is knowledge. And now you can figure out what we're going to do with this. And so Heather, I'm going to come back to you and say, okay, you got these diagnoses. You have BRCA1 and BRCA2. You spoke to Dr. Offit. What happened next?
So, yeah, I mean, just to echo Dr. Frey and Emily, like, I think that it was so important that he said that to me in that meeting, that this is not a death sentence. This is just knowledge is power, and you can move forward from here. And I really want all women and families listening to this to really, like, focus on that because I completely agree with everyone. It's really so manageable and can improve people's lives so much just to understand that this is information and you can do with it what you want. So from there, I enrolled in a high risk program. I was in the MSK program at the time, so it was called the RISE program. It's still around. It's wonderful where you go for screening.
Just tell people what MSK is for the people who don't know.
Oh, sorry. MSK is Memorial Sloan Kettering. They're a cancer hospital in New York City. They have a program called RISE, which is a screening program, which Dr. Frey is now spearheading at Cornell. The same kind of program. So I would go for screening every 6 months to make sure for breast cancer screening. Um, and in terms of like just fast forwarding my story, for better or worse, just, there were many scares in terms of, MRIs and mammograms, and, they had led to biopsies, which thank God were all benign. But in 2018, I had my son. My first child was, born in May 2018, and it just, like, changed everything. I think I always planned to do these surgeries after all my children were born, but, when you have a child, it just for me, put things in perspective, like, it's not about you anymore, it's about your kids, and you wanna be there for them, and, basically, I had one more scan after my son was born, and it was like a double biopsy scan. It was like a very, like, 5-alarm fire, like, "You need to come in tomorrow," and here I am with a newborn, and we're, like, moving out of the city, and it was just a crazy time, but thank God that was benign as well, and at that point, I was just like, I decided to pursue preventative double mastectomy. Um, and the thing of that is too, like, it's a really big surgery. I'm not belittling it, like, it's a very, very big surgery, but there are so many options now for women to pursue in terms of, like, the doctors and the kind of double mastectomy you wanna get, and, I chose a certain path, and I just remember waking up from the surgery feeling so much lighter. I was like, "Wow, this is, like, so wonderful that I did this," and even though it's a very big surgery and you're out of commission for a number of weeks, it just felt like such a good move, and I remember I completely forgot they were gonna test the breast tissue of from the surgery. Like, I completely forgot. I went in for a post-op, like, a week later. My son was, like, 7 months old at the time. We're just trying to, like, get our footing in terms of, me recovering, and my doctor was like, "Heather, like, how are you?" "I'm good, thanks. How are you?" Like, I'm doing okay, relatively speaking." She's like, "Thank God you did this." And I said to her, like, "What do you mean? Like, what are you talking about?" And she's like, "We found precancerous cells, like, over both sides of, like, like, both breasts. Like, this was a
Oh my
blessing you
goodness.
did this. Like, thank God." And I was just like, "What do you mean? I'm 30 years old. Like, what do you mean?" Like, I just couldn't believe it. I was like, she's like, "Look, there's no way to know, like, how long it may have like, how long or, what might have tipped the boat," but she said just like, "I'm so happy you pursued this." And every story is different, right? Like, it's not like I'm, saying everyone has to do X, Y, Z, A, B, C, but, like, for me, like, it was the right move. And, it just made me really appreciate, like, the science is here and medicine's here, and, like, I was able to, like, hopefully like, not have to go through all of that heartache and all of those things. So that was in 2019 that I did that. And it was a Mhm. No, no, I'm saying it was a long recovery. Like, I'm not gonna sugarcoat it. Like, it was challenging at times, but I would do it 100 times over again. Like, I'm not even like, there's no question, you know?
I mean, how much more so? I mean, even looking back, just as you shared that story, I mean, I totally got chills, like, just hearing the doctor say, like, "I'm so glad you did this now." I mean, it's just, uh, it's beyond. It's beyond. Um,
Yeah. No, thank you. Yeah. So it's like, not something I would ever, like, I'm like, "Oh, I wanna sign up for this," but, like, at the same time, it does give perspective. It does I do feel so grateful, and the other thing is I never want BRCA to be, like, the headline of my life. Like, this is, like, we're moms, we're working professionals, we're moving, we're, juggling so many balls, and I'm just so grateful that, the science was there to help me along in this process. Like, I just felt so blessed, honestly, like, just so blessed that this was available.
I mean, absolutely. I mean, just think about it. I mean, I don't know how many years ago. Maybe I'll turn to Dr. Frey and say, like, I mean, when did these surgeries be become an option? I mean, when I mean, it can't be that many years ago where this wasn't even a possibility, right? So, I mean,
Right. The genes were cloned in the mid 1990s, but
I,
there was really minimal access to genetic testing in the 90s. And in the early 2000s, I think there was a lot of concern about genetic discrimination and privacy. And the cost of this testing was several thousands of dollars. So most people didn't get testing. But really, over the last 2 decades, I think that has completely changed. There now is legislation in place that protects against many types of genetic discrimination. And the cost of genetic testing has come down, whereby for many people it will be covered by insurance. And, when not covered by insurance, there's usually an option for kind of an out of pocket payment of $250 or less. And so we're finding more people with these mutations, there's so much more utilization of screening, of preventative surgery, and now it's become really a mainstay in the management of individuals with BRCA.
yeah, I mean, it's absolutely miraculous. And now, like, I want to turn actually to the fertility aspect and the pieces about the next generation, because a lot of people, once they hear this diagnosis, there's two facets, right? There's the what's going to happen to me and what's going to happen to my life, and
Mhm.
how do I prevent, hopefully, like in an ideal world, how do I prevent myself from getting cancer and having a shortened lifespan? And also because, as Emily described, like, these are specific mutations that are passed down. This is a genetic disorder. Some of them are passed down autosomal dominantly. I How do we some people make the decision that they want to prevent their children from also having to go through what they themselves are going through. So can you speak a little bit about that and how you advise your patients who are still within their childbearing years?
Sure, this is complicated because I think there are two ways to think of it. Certainly, there are many individuals who say, I want to do whatever possible to prevent my child from also carrying this mutation. And so then there's something called PGT, which is pre-implantation genetic testing, or some people will call it PGTM, where it's testing for a mutation that's M. And essentially, someone undergoes IVF and creates embryos, and then the fertility team can actually test the embryos, identify embryos that don't carry that mutation, and then when a woman is ready to get pregnant, only reimplant those embryos that have no mutation. And so, for many people, that's a great option. There are certainly other people that say, if my parents had done this, then I wouldn't be me and I wouldn't be here. And so I don't feel comfortable. And I think it's important as a community that we support both feelings about this. And the other thing I think that is very exciting is, in 2025, we have great options for cancer prevention and treatment and risk reduction. Imagine where we'll be in 2 decades when these offspring reach adulthood. There's a lot of exciting sort of data around vaccines that may prevent some of these cancers. And so I think that it's really about what's important to someone. And the other thing that we haven't discussed as much is that, many women find out about BRCA in the setting of a breast cancer diagnosis. And so for that group of people, it's a little bit different because sometimes they have to undergo IVF before starting chemotherapy or other treatment that can affect their fertility. And so IVF becomes sort of the only path towards childbearing. And then again, becomes the question if you want to try to select embryos that do or don't have, or select embryos that don't have the mutation, or if you want to just use, the healthiest embryo. And again, that's a personal decision. I just think it's important for everyone to know the technology exists to do this, and then it's up to families to decide.
I also just want to add for a minute, when somebody is thinking about their fertility and they're BRCA positive, we also recommend that their reproductive partners consider genetic testing as well, because we've talked a little bit about the autosomal dominant inheritance of this, but the autosomal recessive is also a consideration. So listeners may be familiar with, when I was thinking, when I was getting married or planning pregnancies, I went out and thought about testing for things like Tay-Sachs, cystic fibrosis, sickle cell disease. And these are genetic conditions where there's a mutation inherited from both parents, and then those both get passed on to a child. And if they inherit 2 mutations, they can have one of these serious genetic conditions. In rare cases, there are sometimes 2 reproductive partners who are both positive for BRCA1 or both positive for BRCA2. With BRCA2, we can see that inheriting 2 of those is associated with a rare condition called Fanconi anemia, which is a childhood condition that could cause physical birth defects, bleeding disorders. With BRCA1, in most cases, we believe that this is embryonic lethal, meaning pregnancies don't continue if there are 2 BRCA1 mutations, although there are some rare reports of another type of rare Fanconi anemia. So if somebody finds out prior to having children that they're BRCA positive, we recommend that they speak with their partner about testing as well. In addition to the things like Tay-Sachs and cystic fibrosis and sickle cell disease, sort of all of that in terms of how can we consider the genetic risks for the next generation.
Yeah, I love that you added that piece in too because it's not so clear. It's not so clear what necessarily would happen, and also it's important that people understand that obviously you need an egg and a sperm, and just because one person has it doesn't necessarily mean the other person will, but if they do, then there can
Mhm.
be that increased risk. Heather, I
I
want
just
to come
add
back.
one thing,
Yeah, yeah,
one thing,
please.
this is an area of interest for me, and we have a clinical trial where we're offering women cancer genes along with all the other prenatal genes. And we've studied kind of what do women understand about the pregnancy-related genetic testing, and actually about 50% of women are not sure what genes are on the panels that they had, and actually wrongly assume that they already had BRCA testing and it was negative. And I'm not surprised about this assumption. When a doctor tells you they're testing for 200 or 300 genes, many of which are related to Ashkenazi Jewish syndromes, and you're negative, many people incorrectly assume that means BRCA1 and 2 are negative, and for the most part, it is not included on those panels.
Mhm.
Yeah.
Exactly. And if we circle back to the Ashkenazi Jewish population specifically, where you have a 1 in 40 carrier rate of BRCA1 and 2 mutations, that's even a lot more common than a lot of the conditions on these hundreds of panels that we screen for.
Those are amazing. Those are great points because it really gives people the tools and enables them to be able to go back to a doctor and say, actually, was I tested or was I not tested? And then make sure that they do get the testing if they need it. So thank you for sharing that. Heather, I want to come back to you, and you're at this point in your life when you were talking about, what you experience. Your son is 7 months old. You had just undergone the prophylactic mastectomy. I know because of the way you introduced yourself in the beginning of this segment, I know that you have 3 children.
Yeah.
So I'm curious what decisions you had to make and the rationale behind your decisions in terms of when you were considering having more children based on these diagnoses.
Sure. And just to share, I found out I was BRCA positive before any of my kids were born. So I had to go down this road as well, just to make decisions in terms of family planning and if we would pursue IVF and PGT, excuse me. Um, and it's such a personal choice. There's literally I've spoken to so many women about BRCA, and it's every story is different. You have to do what's best for you. There's really no right or wrong. I really want to back it up by saying every situation is different and there's just no right or wrong. For us, for myself and my husband, thank God he was not BRCA positive. So that led to just me being in the loop. But due to the fact that I have both BRCA1 and BRCA2, we had a conversation with one of the IVF leading specialists about this. And he said, nothing's impossible, but just please understand, just to set the expectations, it would probably need multiple rounds of egg retrievals per child. Um, and that if we wanted to read out both mutations. And that kind of begs the question, do you just do one or which one is it then? And then it kind of went down a road of this is and then the other component of it is that I was already aware how fast science was evolving. Science is moving so literally lightning speed. I'm so amazed at how much progress there has been, and I really do believe that in 20 years from now, this is gonna be a completely different conversation. Um, Even if you just back it up to when my grandmother, passed away in the '70s to today, then fast forward 20 years from now, it's just incredible. So my husband and I decided to pursue a family the traditional road, and I think it's just such a personal conversation, and it was not easy, but I really think I respect, like Dr. Frey said, I respect everyone's choices with this, and there's no magic wands, you know what I mean? So it's what works for one could work for the next, and every story is different, and I'm so my kids are my world, I literally am so blessed. So it's yeah, I just think, I pursued the more natural route of traditional family planning. But I totally understand people that, dive into IVF and do that path, and everyone's different. That's really what it is.
100%. Emily, can I come to you just to explain what Heather was saying in terms of she would need to do multiple rounds of IVF in order to be able to even get, a certain number of quote normal embryos. I think a lot of people don't understand that. They think that you can just do a round of IVF and they'll be able to sort of pick out what they need and they'll be fine and go. Can you just give people a window into that process?
Sure. And I think, in the media, IVF is presented in a way that makes it look easy when it's really anything but, and that it's, make some embryos and transfer them, and that automatically results in a pregnancy and a live born. And so IVF is complicated in so many ways. And when you create embryos, there's genetic testing that you can do in a couple ways. One is that has become much more routine now, is looking at the chromosomal complements in an embryo, making sure, do they have the right number of chromosomes? Is there anything extra missing abnormal pieces. So you sort of screen out a certain number of embryos just by looking at those. And it's a decent rate, particularly as the age of the egg increases. And then on top of that, there's a 50% chance for each embryo to carry BRCA1. There's a 50% chance for each of those embryos to carry BRCA2. And so if you're looking at both of those and you say, I'm only looking for an embryo that has the normal number of chromosomes, the normal structure of chromosomes, plus they're not BRCA1 and they're not BRCA2, you're going to be weeding through a lot of embryos that are not usable. And you may or may not get any that meet all of those criteria within a given round. And a lot of this also depends on somebody's specific fertility, how old they are, how many eggs and embryos they're able to create. And once you start picking through the genetic complement of those, there may be a pretty limited number of embryos to choose from.
Yeah, I think it's a perfect way to describe it. I mean, someone once said to me something, it was a reproductive endocrinologist. I think she said, if you think that in a best case scenario, if you are able to harvest 30 eggs, then we're talking about eggs, then I think she said, let's presume that 50% of those fertilize. So then you have 15 fertilized embryos, let's call it. Then you start doing the math of, a half this, a half that. This one might have Downs. This one might have cystic fibrosis. This one might have this. And then you get to the BRCA. She said, and that's assuming that you're starting out with 30 eggs. She said, if you walk away with one embryo that's, quote, normal, she said that would be considered to be a success. And most people, I'll just say it. I mean, you'd have to have a perfect scenario where you would get 30 eggs in a single IVF round, right? So I love the way you describe that in terms of this is just, it's playing the numbers game and it's really hard. And for every family, Heather, back to your comments, if every family makes a decision that's right for them, and IVF is not compatible with some people's medical makeup, it might not be compatible with their psychological makeup, it might not be compatible with them financially. Like there might be a million reasons why IVF doesn't work that has nothing to do with even acquiring a quote unquote normal embryo. So I just deeply appreciate you sharing your perspective and really normalizing the experience of everyone needs to choose what's right for them. Dr. Frey, can you talk a little bit about both you and Emily? I'm going to turn to both of you. How does this journey differ? I mean, Heather is speaking about this experience. She's a woman who's going through this. She's the one who has these diagnoses. How would the conversation be different if your patient was a male? So maybe let me turn to you, Dr. Frey.
I think for starters, men are much less likely to be aware because men do not undergo genetic testing at nearly the same rate as women, because I think there is a big misconception that this won't affect their health, which is not true. As you said, there's prostate cancer, melanoma, and pancreatic cancer. And the other misconception is that these genes are only passed maternally, meaning as long as someone's mom is negative, they're fine, which we also know is not true. Someone can absolutely inherit a BRCA1 or 2 mutation from their father. So I think what we need to start by doing is just education so that hopefully more men will get tested. But for men who do get tested and they are aware, we have prostate cancer screening, and that's done with a blood test called a PSA. We have pancreatic cancer screening that seems to be getting better and better. I think there was a conception that pancreatic cancer is sort of a really catastrophic diagnosis for which there is no screening, and now we know that's not the case. We know that MRIs and endoscopic ultrasounds can catch pancreatic cancer when it is early and potentially curable, and so we would certainly encourage that. And then, melanoma screening with skin checks is something that's very easy to do, and it can also be life-saving. Finally, men also can then be aware that they may have passed this on to a child, or that if they haven't had kids yet, it can be part of the discussion on reproductive care. And so I think for all these reasons, it is absolutely critical that we raise our testing rates among men and women.
I agree with all of that.
Yes,
And
go
I
ahead,
don't
I'm
really
ready.
have much to add because you really covered it. One question which I want to pass to Dr. Frey because I hear this a lot, and I think you're better equipped to handle this. Is a lot of people have concerns about how BRCA1 and 2 mutations can impact fertility, and also if there are contraindications to the medications that go along with IVF and other fertility treatments.
It's a great question. And I think the topic of fertility in BRCA is controversial. There are certainly some publications suggesting um, lower levels of fertility among people with BRCA mutations because when the gene doesn't work, it's an issue with like repairing damage in DNA. And certainly that can affect having healthy eggs and embryos for reproduction. But certainly, I don't think we can say that as a blanket statement. I think more research has to be done to know really what the true implications of fertility are on and whether it is gene specific. Like, is BRCA1 and 2, are they the same? Does it matter what specific mutation someone has? Then the second question is, is IVF, are hormones safe? And I would say yes. There are special protocols that some fertility doctors do, and they know it's a woman who either has breast cancer, had a history of breast cancer, or is at increased risk, where you can basically limit the levels of estrogen to try to make those lower. But overall, it does not increase the risk for cancer. And it does not increase the risk for ovarian cancer, which I know people are very worried about, stimulating the ovaries, and we have not found that. So for someone who's interested in this, it is absolutely safe.
I love that, and it's so helpful for people who are listening to this because, yes, there are some people who will choose, unlike Heather, will choose to go the IVF route and will I and they're wondering whether it's gonna increase their risk or not, and so that's super helpful. Heather, to kind of close us out here, and I wanna, like, have you lead us out and then turn to the 2 other experts here. I you know, looking back now, you have been through all of this, but this is still a diagnosis that you carry. And looking forward to your life in terms of like, is there a hysterectomy or an oophorectomy coming up in your future, or what does this mean in general? The way you think about your health and the way you think about your family, and also, if I could also add just like advice for people who've been given this diagnosis and are not sure about what to do. Okay, I just threw a lot at you, so maybe we should break it down. I'll let you answer whatever you want to answer, and then we'll come
Sure.
back. Go ahead.
Sure. Okay. So, I'm happy to share. Yeah, I did do the hysterectomy in 2023. That was when my youngest son was, I don't know, about the same age, like 8 months old. Oh, actually, it was 2024. Excuse me, it's 2024. And look, like, was it something that was like on my like wish list to do and like block out X amount of weeks and be offline? Like, definitely not. But I am so happy I did it, and our family was complete with 3 kids. I felt so grateful and like blessed to have my 3 healthy kids, and I was 35, and I've spoken with Dr. Perry about this. It's like, it was especially for some, I mean, every story is different, right? But for me, like, I was done with family planning. I um was at the earlier stage of, when they would like it, and because of it's so hard to catch, like, it's not worth waiting. So I did that in 2024, and um look, like, I'm not there are definitely there's a process in terms of, like, figuring out, like, hormone management afterwards, but there's so many options in terms of trial and error, figuring out what works for you, and I'm so pleased to say, like, I figured out what works for me, and everyone can lead, like, normal lives after this. This is not something you have to, stop your whole world for, and people can live full lives. This is just part of your story, and people should just feel empowered to, like, find out what works for them. Like, ask your family history, you know, definitely do checks for, like, breast exams, and, you know, there's very limited screening, unfortunately, as Dr. Frey said, for ovarian side, but I do plan to continue to be followed in Dr. Frey's virus program, and there's medical advances every single day. Look at like what Dr. Frey just said about pancreatic cancer. That used to be like no turning back. Now there's really amazing advances in that as well. So it's just I think like it was a process. I'm not saying it happened overnight. But I am so confident that the whole medical field is going to transform in the next 10, 20 years. I really am hopeful, and yeah, God willing, everyone should just live a full life and appreciate it because it's just a gift.
Absolutely, and the fact that we have the ability to do so. I mean, these are real miracles here. Absolutely.
Yeah.
Dr. Frey, your advice to people who are dealing with this diagnosis for the first time, trying to figure out what to do, where to go, how to manage it, when they should take care of it. I mean, you gave us a lot of statistics already, but maybe, speaking to the people who are scared, can you share a little bit more?
Absolutely. I think, my biggest piece of advice is, find a program or a doctor where you feel comfortable and know that there are resources. And so, as part of our program, we have a social worker who meets with everyone, who helps organize what can be very complex screening and appointment schedules. We also host a support group virtually. And there are many other organizations, national organizations, that have peer matching programs. If you want to speak to someone, if you're struggling with a decision about IVF or whether or not to do a mastectomy, take advantage of these. And I think, there are many excellent programs that are available and in general usually free. And so I'd say this is a diagnosis that is medical, but it also affects every aspect of you and your family's health. And I think we have to appreciate that. And especially as the doctor, we usually come armed with all the statistics and the recommendations for surgery and screening. But I think it's important that everyone acknowledge the other part of this and really work with our patients and their families on that.
It's exactly why we're having this conversation, to give people more knowledge and to be able to let them sort of wrap their heads around what different paths forward are. And, Heather, having you here is tremendous to give people the opportunity to really say, okay, like I've been through this. Look, I'm still standing. I feel good about my future. I mean, it was really, really incredible. Abby, I keep calling you Abby for some reason. I apologize, Emily. This is just my own hang up here. Emily, can you close us out and talk us a little bit more about some of the resources that are available that Dr. Frey mentioned, but also beyond JScreen in terms of different places that people can go to for more information about these specific diagnoses and like getting more support?
Yeah, absolutely. So, one of the organizations that Dr. Frey recently mentioned about peer support is Share It, which is an organization that supports women and families through breast and ovarian cancer, as well as what we call previvors, which is people who carry a mutation but haven't been diagnosed with cancer. So they have amazing resources. There are also some amazing resources for fertility journeys like Stardust and Jewish Fertility Foundation, local genetic counselors. So somebody listening might say, I'm thinking about it. I'm not sure. I want to talk it over. So feel free to reach out to us at JScreen, or a local genetic counselor to just kind of talk through, here's my family history. What do you think? I want to talk through this a little bit more. Those resources are out there. Force is another good one. And then I would also just encourage everyone to sort of talk to their providers and their family members and get a good idea of, what's in the family. What were people diagnosed with at what ages, and to bring that to their doctor and their genetic counselor and have a conversation about it. We've also talked a lot about BRCA1 and 2, but there's a lot of other hereditary cancer genes out there as well. So someone might be listening and saying, I have this crazy family history of colon cancer or pancreatic cancer or kidney cancer, and this doesn't really sound like my story, but it does seem like a lot of people or, young ages. And I'm really concerned about this family history. So I encourage people to really gather all of that information, bring it to their doctors and genetic counselors. Also consider updating genetic testing over somebody's lifetime, right? We've talked a lot about medical advances, and that's true of genetic testing as well. Whereas, we used to only be able to test for 2 genes or even a certain number of variants within a gene, and now we can test for dozens at a time. So to kind of just keep up to date on your own personal health and your family histories, health, and reach out to these resources as needed.
Thank you. That's invaluable, invaluable information for anyone out there. I can't thank all of you enough for being here and sharing your stories and sharing your expertise. It's really a privilege to sit with all of you and know that all of you are really helping to change the community and giving people the tools and empowering them to be able to change their lives. So thank you so much for everything.